Good afternoon, everybody. We're just waiting for a couple more people to join. We'll be starting in about a minute's time.
You can start sharing, Dr. Conradie.
I tried. Good afternoon, everybody, and welcome to tonight's talks. I hope wherever you are that you have power and no COVID. Today, what we're going to be talking about is TB and HIV. My name is Dr. Francesca Conradie. I work for WITS, and I am an ex-HIV clinician, and I now work in the field of TB. What we're going to talk about is we've actually got a pretty mixed bag of presenters here today. First of all, we have Dr. Limakatso Lebina, who's going to be talking about targeted universal testing for TB. Then Professor Harry Hausler will be talking about TB preventative therapy for people living with HIV. We have a clinical hematologist, Dr. Estelle Verburgh, who's going to be talking about the diagnosis of lymphoma in TB suspects. And then finally, Ms Monica Longwe is going to be talking about the TB response plan post-COVID. This will be followed by question and answers, and we plan to end the session at about 7:30. Thank you very much for joining. I'm not sure where in the country everybody is, but we've just had a very severe thunderstorm, so that we might have lost a couple of people. We're going to, the first question that we always get asked at a webinar is what's going to happen to the slides. Please be patient. They will be available on the South African HIV Clinicians Society website. You'll be able to get the link. In terms of question and answer, it's always very difficult on a Zoom call to have voice question and answers. So please, if you could ask your question in the Q&A box. I can multitask, and what I'm going to be doing is I will be looking at the questions and particularly looking at themes and bringing them out towards the end. And if you are a member of SACS with a good standing, you are eligible for CPD points for the CME education. In terms of thanks, I would like to say that we, the South African HIV Clinicians Society, did not receive, I beg your pardon, we did not receive the results. Sure, technology is always one thing that gets to me. Hang on a second. We did not receive the results without this. We would not achieve the results that we have, which is impacting on international and national guidelines for HIV treatment and management and all comorbidities. And this meeting was made possible by our partnership with the Aurum Institute. I'm going to stop sharing now, and I'm going to hand over to our first speaker. Dr. Limakatso Lebina is a medical doctor with a diploma of management of HIV management, an MPH, as well as a PhD. She's worked in multiple clinical trials at the Africa Health Research Institute, as well as observational studies in TB, HIV, and COVID. She's been a co-author of many publications and presented at many local and international conferences. She's been a member of the TB think tank since 2019 and is leading, and it kind of makes sense that this is her presentation, is leading our aim to find the missing TB patients in South Africa. She's worked on finding with the missing TB patients, looked at the LAM guidelines, as well as systematic screening for TB. She's also a member of the BRICS TB Research Network. Dr. Lebina, I'd like to hand over to you now. Thank you very much.
Thank you for the lovely introduction. I hope you can hear me and you can see the slides.
Yes, we can see you. We can't see the slides yet.
Oh.
Isn't it weird? What stresses us most about these meetings is the technology.
Yeah.
Or maybe I'm just speaking for myself.
No, all
Carry
of us.
on.
You are not the only one. Yeah. But I hope they are sharing now.
Yes, we've got them.
Yeah. Trying to change back to presenter mode. Not sure why that's not working today.
That's weird because I can see you clicking on it.
Okay. Yeah.
There we go.
Thank
Off you go.
Thanks.
Thanks.
And thank you very much for your patience. So my talk this evening is entitled Targeted Universal Testing for TB in Clinics in South Africa, a cluster randomized trial, which is a study that we conducted pre-COVID and with a team of other researchers from various organizations in 3 provinces in South Africa. And I would like to acknowledge my colleagues that contributed quite a lot to this work. And as a background, we have seen now over the years that symptom-based screening for TB is inadequate to identify all the TB cases, especially among those that are HIV infected. It's often very difficult to get everybody who's possibly having active TB disease diagnosed if one just relies on the symptom-based screening of the 4 classical symptoms of cough, fever, loss of weight, or night sweats. And this is also been more complicated to sort of enhance what we've been doing for TB case detection following the COVID, where we know that there was disruption in healthcare services access, there was disruption in treatment completion, and some people are still just uncomfortable to access health services with the fear of COVID. And as a healthcare systems across the world, we need to do more to find people with active TB disease if we want to reach some of our targets of reducing morbidity and mortality associated with TB. And sometime last year, the WHO released new guidelines on targeted universal testing for TB or systematic screening for TB in communities at high risk of TB, and they consider such communities to be those with a prevalence of about 0.5 to 1% or even higher. And these guidelines give various recommendations, various algorithms that could be followed to screen for TB, not only just relying on the classical symptoms, but also to start investigating people that are considered to be at high risk, and using various investigation methods, whether it's a gene expert, whether it's C3 protein, whether it's chest X-ray, to then combine that with in some algorithms with the symptoms to then be able to find whose people are probably having active TB disease. And in that background of the missing TB cases, as we know, the sort of diagnosed or confirmed according to the reports is about 7 million TB cases per annum, yet the prevalence estimates are that we should be diagnosing about 10 million per annum. So there's always that missing gap of about 3 million TB cases that are not diagnosed or started on TB treatment each year worldwide. And in South Africa, those estimates were about 150,000 TB cases that need to be diagnosed if we could do more in terms of our screening and investigation for TB. And so we then planned to do this study a few years back, which we finished last year, which was to ascertain if augmenting standard care, then the standard care was a symptom-based sputum testing with targeted universal testing in clinics will increase the number of patients diagnosed with TB per month by 25%. And the high-risk groups that we were targeting were patients accessing primary healthcare services that are HIV infected. They are close contacts of a TB index case in the last year, and persons who've had prior TB in the last 2 years that have completed TB treatment and could be accessing healthcare services for any other reason. And the main really outcome of the study was to then assess the number of TB cases diagnosed per clinic per month and compare that with the prior data or historical data, and also compare intervention clinics to control clinics to say if there has been an increase in the number of TB cases diagnosed per month per clinic where the intervention was implemented. So the study design was that we were looking at 60 clinics. The study was implemented in Gauteng, KwaZulu-Natal, and Western Cape. And those 3 provinces were targeted because of the high prevalence and incidence of TB. And we had 8 clinics in Gauteng, 26 in KwaZulu-Natal, and another set in Western Cape. So the study design was that we will have 30 clinics that will continue with the standard of care, but to collect data a year prior to that in terms of TB cases diagnosed per month. We used the CDW data or central warehouse data to then see which clinics are actually diagnosing more TB cases per month. And we try to look for those that are diagnosing up more than 10 cases per month, and then stratify them into either intervention or standard of care. And the standard of care, we just continued collecting the data in terms of the number of cases diagnosed. We also visited the clinics to observe if they are implementing the standard of care according to the guidelines of screening every patient with TB symptoms and referring those that might be having active symptoms to be investigated for TB. And if there were concerns in terms of adherence to guidelines, those were reported to either the facility manager and or the provincial TB coordinator, depending on the setting and the issues that had to be raised. In the study intervention clinics, we had then 30 clinics that received both the standard of care as usual. Things continued. If patients with possible TB symptoms were identified, they will then be investigated for TB. But what we also do is we had field workers that were based in each of those clinics who would give information about this study and consent to those that are interested and meet the criteria. That is being HIV infected, being a contact of a TB case in the last year, and previous TB in the last 2 years. And if you agreed to be part of the study, then the field worker will show a video about how to give a sputum sample for investigation or direct the person where they can give up the sample. And then following the sample collection, then we'll ask about TB symptoms. So that means everybody was investigated irrespective of the symptoms they had. And some of the people said, I'm not coughing, and they'll be asked still to rinse their mouth with water, like everybody, and cough repeatedly until a sort of sufficient sample was obtained. And those that were part of the study were then investigated with both gene expert and TB culture. But one sample was taken to the laboratory that could be able to split the sample into expert and culture. So yeah, that was the plan. But we ended up with about 10 clinics. We had to drop 2 earlier and replace them. That's how we ended up with 10 clinics in Gauteng. Because there were other ongoing studies in those 2 clinics that we thought would interfere with this, the targeted universal testing study. And then we had 26 clinics in Western Cape, as previously indicated, and 26 clinics in KZN. And some of the clinics were either ineligible because they had either too big sample in terms of the number of TB cases diagnosed that they'll sort of skew the analysis. Some were too close to another, and it was thought it would not be good to have 2 clinics adjacent, one as intervention as control. So then we will choose within a certain proximity, we will take only one. And the randomization ratio was 1:1 in terms of intervention and control clinics. And we started implementing the study in March 2019, and we had hoped to implement in all the clinics at the same time and have data collection ongoing for about a year or 13 months, so that we sort of eliminate the low data collection at the beginning. But as the challenges of implementation research is that quite often you don't have everything when you need it. And so the approvals were delayed in some of the provinces, in some of the clinics. And we're concerned that if we wait until everybody's on board, we continue to spend the resources that were allocated to the grant, and we might not have sufficient time to then get the data. So we started collection in some of the clinics where we could in March 2019. And as you can see on the graph, we sort of added more clinics as time went by. And the idea was each clinic will still have about a year of intervention. And there were some clinics that were expected to end in about September 2020. However, after the COVID situation, when we had paused to see if we can restart those clinics that had stopped, the TB access services dynamics changed so much that it was difficult then to say the data will be comparable. And by the time access opened in about June, we only had a few clinics that we could say maybe we should still be collecting data. So a decision by the study team, as well as the guidance from the DSMB members, was that we end the study at the end of March when we closed for lockdown. That was then the end of our data collection. And
sorry, Limakatso, there have been a couple of requests for you to make your slides bigger. I'm not actually sure how to do that. So maybe if someone from SACS could help. They're fine on my side.
Yes, they're also fine on my side. Those people, maybe it's worth checking your view. In the top right-hand corner, there should be a little button that says view, and on there, just ensure that it's on standard, as opposed to side by side or gallery.
Or full screen, and then it occupies your whole screen.
Okay, thanks. Let's go. We can carry on. Thank you, Limakatso.
Okay, thank you, and apologies for those that cannot see properly. I hope the explanations will fill in the gaps. So this is just trying to show the activity of data collection or presence of a field worker in the various clinics, and we're sort of measuring the fidelity as well as the intensity of the intervention. And in most clinics, we're able to have a field worker for more than 9 days in a month, 9 working days. And only a few times then somebody fell ill and we were not able to replace in time. And the red is when we didn't meet those targets, and it's mainly because of the clinics that started late. And as we continued enrollment in the intervention clinics, in the period that we're in the clinics, we're able to have 32,942 patients consenting to be part of the study and investigated for TB. And we got results back for over 90% of them. The median age of the participants was 39 years. And as it is with the healthcare access, 62% of them were women. After sputum collection, the participants were then asked if they have symptoms. Only about a third had some symptoms of TB, and some were not even documented if they had already consulted. In terms of risk factors of participants that were enrolled, 71% of them were enrolled because they were HIV infected. 28% were TB contacts, and 1% was previous TB. And as you can see, the numbers do not really add up to 100% because some of the participants had more than one risk factor. And among those that were HIV infected, the median CD4 count was 42. Okay, and these are sort of the overall results on TB positivity. It was about 5.9% of all the people that were investigated, and we confirming again that symptomatic screening, if it's done properly, it's still maybe one of the easiest way to pick up some TB cases, although it's not all of them, because if you check among those that said they were symptomatic after sample collection, about 10% were then diagnosed with TB, whereas among the asymptomatic, that was 4.4%. And then if you look by the risk factors, the percentages also changed quite a bit. About the HIV infected, it was 5%, and it increases more if you're HIV infected, and symptomatic as well goes to 9%. And those that were TB contacts was 7.5%, and prior TB was 12%. Although the TB contacts and the prior TB were sort of having the highest proportion of TB cases, were also in the lowest number investigated, as previously shown in the previous slide. This is concordance between GeneXpert, culture, and comparing the results. And as you can see, there's quite a good concordance between Expert Ultra and culture. With the only challenge is about the Expert Ultra trace, with only about 10% of those being culture positive as well. And I think this also just covers and looks more at the comparing in terms of the method of testing that was used, whether it was trace, and if we exclude the trace, what the proportion that were found to have TB, and if you exclude trace and or only consider the ultra and culture positive together, that gets about to 6%. Looking at ultra and or culture positive, trace included 8.3%, and number needed to test overall was 17, and among the HIV infected, number needed to test was 20. And this looks at the clinic level data, which was really the main objective of the study, to see if targeted universal testing increases the number of TB patients diagnosed per month per clinic. If you look on the left, the graphs comparing the standard of care clinics and the TAT clinics, and on the x-axis is sort of the number of cases diagnosed, on the y is the clinics, not in any particular order. But as you can see in the standard of care over time, the number of TB cases diagnosed got less from compared to historical period, whereas in the TAT intervention clinics, the number of TB cases diagnosed per month increased, but it was also not in all the clinics. In some of the clinics as well, the number of TB cases reduced, and in some there wasn't a major difference. But if you look in terms of the overall sense, you can see more clinics in the chart had an increase in the number of TB cases diagnosed. And in the table adjacent to that, we summarize the standard of care clinics and the touch clinics, looking at historical data and the study period data. And in the standard of care clinics, you can see that the median number of TB cases diagnosed per month dropped by about 1.5, whereas in the touch clinics that increased by 1.2 cases diagnosed per month per clinic. And we then did additional analysis to assess other things in terms of this outcome or objective of the study, comparing the touch clinics and the standard of care clinics, as well as comparing the historical data and the study period data. And there was about a 14% increase when we adjusted to prior period and clinic volume and province in the touch clinics compared to the standard of care clinics during the study period months. And unadjusted analysis was approximately 8% reduction comparing the standard of care clinics to prior period, and touch clinics study period data versus historical data. There was about a 5% increase in the number of TB cases diagnosed per month, and the difference in regression adjusted analysis for each province showed that there was approximately an 8% reduction in the standard of care clinics historical data compared to or study period data. And looking at the study arm by period interaction, there was a relative increase of about 17% in the number of TB cases diagnosed per month per clinics in the intervention clinics. So in summary, is that using either expert or culture, there's about an 88% TB prevalence in the 3 high-risk groups that were included in the study, which were patients attending primary healthcare facilities for various reasons, not necessarily presenting because they are concerned about their respiratory symptoms or that they are concerned that they could have TB. Intervention clinics diagnosed about 20.7 cases versus 8.8 cases per clinic per month in the control clinics. Although there was no statistically significant increase, but there was an increase of 14% more TB cases diagnosed if you adjust for prior period clinic volume and province. And as highlighted, the difference in difference analysis showed that there was a relative increase of 17% more TB cases diagnosed in the intervention clinics. So systematic screening with expert and/or culture diagnosed more TB cases in clinics, overall 6% if you exclude some of the trays, and 5% in the HIV infected people. And clinics are actually diagnosing 8% fewer patients with TB year on year under standard of care. And the start intervention resulted in a relative 17% net increase in TB cases diagnosed per clinic per month as compared to the standard of care clinics. So based on this data, it would be recommended that systematic screening with expert should be done in some subpopulations or groups of people that are considered to be at high risk of TB. And of course, more research and analysis needs to be done in terms of the cost effectiveness of such an intervention. And I would like to acknowledge the many people that contributed in this study, our funders, our collaborators, and we're also very much grateful to the patients and the staff at the participating clinics. Thank you very much.
Thanks very much for that. That's an impressive piece of work. That's really a lot of patients that you managed to go through. Before I go any further, there's one question, and the question is from Yunus Musa. And I guess I'm going to ask his question as well as my own at the same time. So what happened to these patients? How many of them were initiated on therapy? And Yunus's question specifically is around what you did with those patients that were diagnosed with a trace on GeneXpert Ultra. I think we've just lost our presenter due to load shedding. It's now 6 o'clock. And for those of you that are going to get load shedding, I guess it's just happened. I'm sorry, I can't answer all these questions, but what we will do is we are going to ask the presenter to please jot down the notes. Isn't South Africa a wonderful place to live in? Full of exciting stuff happening all the time. I'm now going to move on to our next presenter, who's Harry Hausler. Harry Hausler is actually a family physician, and he's been an HIV clinician and a public health specialist for 28 years. He's particularly been working around what we call the key POPs. So that is inmates in correctional services, adolescent girls and young women, sex workers, and people who use drugs in South Africa. Harry is the chair of the Civil Society Forum in the Western Cape and co-chair of the Provincial Council on AIDS and the chair of the TB Prevention Task Team. He's a member of the Civil Society at SANAC, so he's got many hats that he wears. And I'm going to hand over to Harry to ask you please to talk about the new National Department's health guidelines on TB preventative therapy. Thanks very much, Harry, and we're ready to take your talk.
Thanks, Francesca. I'm just going to try and do the view swap to presenter mode. Can you see my slide now?
So it's not showing full screen.
Yeah, that's what I was about to say. It's not showing full screen.
Okay, let me stop sharing.
Or just go on to Use Slideshow at the top.
Yeah, I'm actually on that, so I'm going to.
Because we're getting a hint of what's coming up. We can see a strip of your slides at the bottom.
Right. Here's the swap displays. This should be good.
Not yet.
Okay, almost there. Let me see. Okay.
What I'd like to design is a simple front end to all of the presentation things that we have to do. It would make our lives a lot easier. Thanks, Harry.
Okay. So do you see the first slide now?
We do. Thank you.
Full screen. Great.
Yes.
Thanks, Francesca. And thanks to Limakatso for that excellent overview of the targeted universal TB testing results. And so you'll see that those results actually had an influence on the TB preventive therapy guidelines, as we'll see as we go along. But I'm going to start by discussing the Ntv strategy and where TB preventive therapy fits into that, and then reflect on the United Nations high-level meeting commitments made in New York in 2018, review the most recent update of the WHO TPT guidelines, and then and reflect on what the previous guidelines are and what's coming up, and then considerations for implementation, and finally a call to action for TB prevention. So if we look at the Ntb strategy, and just checking, Francesca, are we on the Ntb strategy slide now, just to be sure?
Yes, we are.
Okay, great. So you can see that the Ntv strategy has three pillars, and the first and second are important for TPT because first one is around integrated patient-centered TB care and prevention, and then bold policies and supportive systems is also important because there are new TPT regimens that are shorter and have less side effects. So in pillar one, there are a number of elements, including early diagnosis, treatment, collaborative, TB HIV collaborative efforts, and then TB preventive therapy for people at risk, as well as vaccination. And here is just to look at the modeling that has been done on what is needed for us to reach the NTB targets with a 90% reduction in TB incidence by 2035. And you can see quite clearly that just mitigating risk factors or treating TB infection alone are not enough, but treating TB disease and infection will achieve that very ambitious target. So in New York in 2018, the president of South Africa, President Ramaphosa, attended, and with many other world leaders committed to a number of targets by 2022, including at least 30 million people receiving TPT globally. But just note that for those targets include children under 5, and 4 million and 6 million people living with HIV. But the biggest bulk of that 30 million are other household contacts. And that was quite a paradigm shift, really, in thinking about TPT, because to date, and still in South Africa, have only focused on people living with HIV and child contacts. So here you can see all of the various UNHLM commitments with the 30 million TPT. And for South Africa, you'll see as well the targets for South Africa for each of diagnosis and treatment and MDR, and 2.6 million target over that period for TPT. Just also to note, the WHO has really tried and done an amazing job, I think, in pulling a lot of different guidelines together in one easily accessible document. The one that's shown here, it says latent TB infection, but in fact, I'm wondering whether you can see this one, but it's basically a module on TB prevention that came out in 2020, and that's easily accessible on the WHO website. But just to summarize then the recommendations from the WHO guidelines are that adults and adolescents living with HIV should be offered TPT, including pregnant women and those who've been previously treated for TB, irrespective of the degree of immunosuppression. So it doesn't depend on a CD4 count, certain CD4 count, and also the testing for latent TB infection is not required. For infants and children living with HIV, infants under 12 months living with HIV who are contacts should be offered TPT, and any child over 1 year of age living with HIV should be offered TPT, as well as children living with HIV who successfully completed treatment for TB disease can also be offered it. And then household contacts, this is a big change now for not just child, but adolescent and adult household contacts. Contacts of people with bacteriologically confirmed pulmonary TB who are found not to have active TB may be offered TPT. And then other people at risk have also been identified, particularly people initiating anti-TNF treatment or receiving dialysis, organ transplants. Silicosis in the context of South Africa is quite important in the mining community. They can be offered TPT, and systematic testing for latent TB infection with tuberculin skin test or IGRA is not required. And TPT is not, even though people with diabetes and harmful alcohol use and smokers are all about twice as likely to get TB, and malnutrition is quite a big risk factor. Currently, TPT is not recommended for those risk groups. So the algorithms to rule out active TB then are to be screened using the symptom screen. So no cough, fever, weight loss, or night sweats. Then people can be offered TPT. And then chest radiography may be offered, but is not required. And now in the context in South Africa, there was quite a big move through Global Fund resources to make digital chest X-ray with artificial intelligence assisted diagnosis available, but it's still quite limited currently in terms of accessibility. So the guidelines that WHO now recommend include 6 or 9 months of daily INH, or a new regimen is 3HP, which is a 3-month regimen of weekly rifapentine plus isoniazid, or a 3-month regimen of rifampicin and INH. And then in 2020, the 2 additional regimens that have been recommended as alternatives are 1 HP or 4 months of rifampicin. So just looking way back to 2013 in the ART guidelines, at that stage, there was the differentiation based on CD4 count and whether TST was available or not. But it was made clear already at that time that tuberculin skin test is not required to initiate a preventive therapy. Then in 2018, Dr. Pillay, when he was still the DDG, signed a circular that noted that while South Africa has done actually quite well in terms of implementing IPT, is isoniazid preventive therapy, it was 41% of the global total at that stage, but nonetheless, only half of people living with HIV, people in HIV care, had been able to access IPT. So it was felt by the national department that something needed to be done to scale up IPT. And one of the main changes was that TPT, IPT could be initiated at the same time as initiation of antiretroviral treatment. And then also to scale up TPT for child contacts, and just to note that the tuberculin skin test was no longer required. Then if we look at the antiretroviral treatment guidelines that were published in 2019, but then updated in March of 2020, this is what most of you will be familiar with now. Clearly, again, stating no need for tuberculin skin test and recommending that isoniazid be given. The reason that South Africa uses a 12-month regimen is because of a study that was done actually here in PLHIV, showing a 12-month regimen decreased incidence of TB in people living with HIV. So because that regimen was assessed here, and longer durations of isoniazid have been shown to be beneficial. It's the recommendation is 12 months of INH. But for child contacts, only a 6-month regimen. And pregnant women at the time of the antiretroviral treatment guidelines, because of the APRISE study that had indicated or adverse pregnancy outcomes, it was limited for 8 people pregnant women living with HIV with CD4 counts less than 350. But now the new guidelines that have been finalized by the TB think tank, and I chair the TB prevention task team of the think tank, they were submitted to the department beginning of October of this year. And it's really, they've been updated based on the WHO updates. And some of the key issues are that people living with HIV, including pregnant women, regardless of CD4 count, and all close contacts, should have access, as well as the other clinical indications that you can see there. And then ruling out active TB disease really based on the findings of the TUT study, are that there should be universal TB testing for people living with HIV. So sputum collection for gene expert for people living with HIV in close contacts. If chest X-ray is available, it can be used, and no need for TST or IGRA. And we've added the 2 new regimens, and the advantage of this was 3HP. It's only 12 doses. The adherence is better, and there are less side effects. And then for children, there's a pediatric friendly formulation of rifampicin and INH that's available now. So I'll just go through these algorithms, and you will have access to the slides. But the overall approach, whether for people living with HIV or any other risk groups or household contacts, is that people should be evaluated for TB disease with the appropriate tests. And if there's no TB disease, offer TPT. If not, they should start they should start TB treatment if they have symptoms, rather. And if no symptoms, no evidence of TB disease, they get TPT. So now specifically for people living with HIV, we've added in sputum testing with expert, but as well now the lateral flow LAM, the LAM assay, which is the guidelines are available, so that the urine LAM should be offered at primary healthcare level to people living with HIV with CD4 count less than 200. And so if the LAM or the expert is positive, or if there's a chest X-ray is suggestive of TB, then people should be treated for that. But if those are negative, then and there's no symptoms, then TB preventive therapy can be offered. Now, it's a similar approach for contacts, but here we don't have the LF-LAM, so we do have the gene expert. Again, chest X-ray available with a similar approach. And for drug-resistant TB contacts, you can refer to the DRTB clinical reference guide that Francesca, I think, was very much a part of putting together. And that provides recommendations for TPD regimens for contacts of drug-resistant TB patients, but that's not in this guideline because it's covered there. And then just for children, whether child contacts or children living with HIV, here there are no signs or symptoms. With chest X-ray should be done if it's available, and if there's no sign of disease, TPT, and then testing, and if any of the tests are positive, then they should be offered treatment. And then finally, for the TB exposed infant, again, there's an assessment, and if the infant is the contact of a mother who's been on treatment for greater than 2 months and has responded to therapy and considered not infectious, so the sputum is converted, then there's no need for preventive therapy. But for HIV positive infants, 6 months of INH is recommended, and for HIV unexposed or uninfected, HIV exposed but uninfected, not on post-exposure prophylaxis, then they can be offered the child-friendly regimen of 3RH. So just a few considerations for implementation. The main point here is that we need to integrate contact tracing, testing, treatment for gene expert positive, and then TPT for those who are gene expert negative. So it's a household kind of approach that's done so that everybody in the household is assessed and either gets treatment or TPT. And there needs to be education and counseling. And part of the rollout of TPT, definitely we need education of patients so that they start asking for it if they're eligible for it. We need to do clinical follow-up to monitor for safety, support adherence, do weight checks, particularly for children, that's important, with dose adjustments. And monitoring and evaluation should include the number of contacts who've been tested and TPT started, completed, or lost to follow-up or died. And ideally, we need to integrate this into our CCMDD program, or the repeat prescription collection strategies, or differentiated service delivery, differentiated models of care, many names for basically making it easy for people to access their chronic medications. At facility pickup points, adherence clubs, or at external pickup points. And these are the building blocks that the International AIDS Society has really been promoting, but thinking about screening for TB. When should it happen? Where should it happen? Who should do it? And what should be done? And then initiation of TPT would be done at a health facility. So the screening can be done in the differentiated models of care settings. But the initiation will need to be at a health facility, clinical follow-up at least at 1 month, 6 months, and 12 months. And the refills can be ideally aligned, especially for people living with HIV, with their antiretroviral treatment refills. And then completion of TPT would be assessed at the annual evaluation. So the next steps are, we had tried actually to get the DG of the National Department of Health to sign off these guidelines without having to go through to the National Health Council. But the department does really require that this goes to the National Health Council, where the national minister meets with all of the provincial ministers and DGs to get final sign off. And so I've been informed by Dr. Njeka that it's not going to come to this meeting, but the next meeting after, so possibly December or January. So we're really hoping, the indications from the National Department are that these guidelines will be effective early in 2022. Then we have to have intensive training of clinicians and treatment literacy of patients, the integration into the CCMDD. The clinical records should be updated. We already have in the HIV clinical records, there's space for TPT evaluation initiation, and it's in tier already. So the only revisions will need to be to add the new regimens with different durations, and then also to add household contacts. But one of the key barriers for the 3HP rollout is, unfortunately, it's still quite expensive. There's only one pharmaceutical company, Sanofi, that currently provides rifapentine in South Africa. And unfortunately, it's not in a fixed dose combination with INH. There is a fixed dose combination 3HP formulation that's been submitted for approval to SAPRA. So we're very hopeful that that will become available and that the price will go down early next or sometime next year, because that would really facilitate the nationwide rollout of this effective regimen. But unfortunately, we have a real wake-up call from the last global TB report. I attended the Ntv Summit as a member of the WHO Civil Society Task Force over the last 2 days. And the last global TB report showed a 21% reduction globally in TPT. Most people provided with TPT are people living with HIV, so that's great for the HIV program, but we're way below the targets for household contacts because the guidelines haven't been adopted yet. So here you can see that globally for the UNHLM targets, only 29% of the global targets have been reached, but fortunately the PLHIV targets have been already reached and exceeded. So the last point I wanted to raise is that I did participate along with many other partners, civil society partners, and different governments and WHO staff in a high-level event in June. There's now a global call to scale up TB prevention. And so it's really time for South Africa to heed that call. These are my contact details, and I'm happy to take any questions. Thanks very much.
Thanks, Harry. You know, what I always found about TB preventative therapy is it was so complicated. There was the skin test, yes and no, and the duration. And it's great to see the more complicated it is, the less likely it is for people to do. And it's fantastic to see that it's now been simplified. And I think a great step forward is that everyone in contact with someone who, all household contacts, irrespective of their HIV status, should be provided with TPT, because before it was almost stigmatizing. So it's great to see those steps forward. We've got a couple of questions in the question and answer session, and I'm going to just start going through them. I think the first one is, and if I may take the chair's prerogative to also ask some questions myself. Now, we missed millions of patients. We started them on antiretroviral therapy, but we never gave them IPT. So what is the plan to find those? And when we have stable patients, patients with suppressed viral loads, do you think it's safe to give 3HP through CCMDD? Safe and not only safe, but it's a good thing to do. Thanks.
Thank you. Those are excellent questions, Francesca, and I completely agree with you that we need to simplify, and I think there's been these new guidelines have really simplified the approach. Absolutely, the people who are stable on ART, I mean, if we have 5 million currently, I think, people on ART in South Africa. So every single person living with HIV should be assessed at their next clinical assessment to see, have they ever had a course of TPT? Now, currently, the guideline is only for one course of TPT, but there still needs to be an assessment of whether they've ever had access to it. And if they haven't, then they can be offered it. There were some questions about rifapentine and drug-drug interactions with dolutegravir. And so the recommendations are not to initiate someone on TLD and give 3HP. So the recommendation, but for those people who are on TLD and virally suppressed, there's no problem. So absolutely, they can be assessed, and they could access 3HP through a CCMDD mechanism. I think with 3HP, because it's a new regimen, it's still suggestive that there should be some kind of an evaluation or clinical assessment for side effects on a monthly basis, but they could get a whole 3-month course and then be assessed along the way.
Thanks for that. So, in other words, we can still keep an eye on the patients who are stable. We must remember to go and find them and make sure that if they haven't had it, they should get it. And there's no reason to be paternalistic. We can explain to patients why it is necessary. So, Tsitsi, the question that you're asking is, if there's any guidance on repeating TPT for people living with HIV in the setting where TST and IGRA is not an option. So should we give IPT more than once? I think, Harry, if I could hand that over to you, I think you have answered it. And also Louise is asking a similar question.
So it's not recommended to be repeated. If the eligibility for the TPT was living with HIV, then one course is sufficient. But if someone living with HIV is a close contact with an infectious TB patient, then they would be eligible for a repeat course, because then it's, because they're at increased, we know that people who are in close contact are at increased risk, so then the TPT would protect them. So then it could be repeated, but just based on HIV status alone, it doesn't need to be repeated.
Yeah, that makes sense. I think, as we go along in 3 or 4 years' time, we might change that guideline. But what we are saying right now is, if we could just give everybody who's living with HIV at least one course, I think we would make a big difference. And then Anita Johnson is asking, should we give TPT after completing MDR TB treatment? Yes or no? I'm going to bat this off to Harry, because I think that the answer in our current guidelines is probably no. What we tend to do is we tend to follow our MDR TB patients for at least a year afterwards to look for relapses. And then I guess the clock resets, and you might, if they haven't been offered IPT, you could consider giving it, or other forms of TPT. But Harry, do you have any other suggestions on that?
No, I think that's sensible. I would agree. I agree with you. We haven't actually specifically covered that in this version of the guidelines, because there is the DRTV clinical guidance. But I think that makes sense. But the point about people after a course of TB treatment for drug-sensitive TB certainly could have a course of TPT. So that it would be fine. And then I see as well, there was a question about drug-induced liver injury, and there's very low incidence of hepatotoxicity with TPT. It does exist, so there is a need for monitoring, but there's no need for collecting liver enzymes and monitoring, in that way. It's more to do with patient education about potential side effects and encouraging people, if they develop them, to come back for clinical assessment.
Thank you. And then, so if I can just take 2 more questions, then we'll go to the next speaker. The first one, I'm going to answer loud and clear to you and Tommy. Have we changed our guidelines to include women with CD4 counts above 300? Yes.
Yes.
As Harry has mentioned, that there is a process through which these guidelines are being ratified, but the bottom line is that we are now advocating that pregnant women, irrespective of their CD4 count, should be given TPT. That's where many of our diagnoses of HIV are made. And if we put them on the never, never plan, we may lose them. And the risks of hepatotoxicity as well is low. And then finally, Eunice, you keep popping up here. Why do we give TPT after completing TB treatment?
Well, there's clinical evidence that it is effective, because people with, as we saw under the targeted universal TB testing study, that people who've had TB in the past 2 years that are at increased risk. So TPT has been shown as secondary prophylaxis to be effective in clinical trials.
Great. And I think that it's across the board, this introduction of IPT for women who are pregnant, fall pregnant, who are thinking about falling pregnant, irrespective of their CD4 count, it should be answered. Camilla, do you want to take that one?
No, sorry, Francesca, I was just clearing it there for you.
Oh, thank you very much. I just saw your name popping up. Okay, I think that sorry, in the interest of time, we're going to go to our next presentation. This is a complete change. What we've been doing so far is we've been looking at this a public health approach to the prevention of TB. Now we're going to do something completely different. Professor Estelle Verburgh is a clinical hematologist, and she's an associate professor in clinical hematology at the University of Cape Town. Her research vision is to devise timely and cost-effective strategies for hematological care in Southern Africa, and to make hematological diagnostic approaches more accessible to non-specialists. She's a member of the many hematological societies, and what she's going to be talking about is, as HIV clinicians, our instant fallback position is if there's a lymph node or an effusion, it's TB until proved otherwise. And what Estelle is going to be talking about is she's going to be talking about an approach to the diagnosis of something other than TB in this group of patients. I'm handing over to you, Estelle. Just waiting for your slides. Okay, we can see you. Are you still on mute, Estelle?
I was unmuted, but, oh, sorry.
I know.
Let me just get this. I did try to, it gives me, for some reason, a whiteboard.
Yes.
Let me try again.
It's
It's
always
Microsoft
reassuring.
PowerPoint, the right name, the right, for some reason,
There we go. We got
I've
it.
gotten there. Okay, great. Let me start the presentation. Thanks, Francesca. You've been cheering us on to get through the tech difficulties. So indeed, it is a change of pace. Please bear with me. I'll try to be true to my research vision, namely making hematological diagnosis more accessible to non-hematologists, because seriously, honestly, you are the guys making the diagnosis, not me. And it's not fun to be clever after the fact. It's important to actually share what we think is an important topic, namely making the diagnosis of lymphoma in a TB suspect. So there are not many bacilli in the lymph node, and an FNA is not necessarily the best test for it, although FNAs are being done all the time. And negative, when you're not testing the right tissue, is not really negative. It's simply not done. So there's huge delays for us who want to treat patients with lymphoma. And remember, in the developed world, HIV, lymphoma is the biggest killer in HIV patients. In our country, it would probably be TB, but in other settings, it's a huge thing, also in HIV patients. So HIV and TB, you can't pick them apart, really, when they present often in a extrapolary way. And when faced then, the clinician facing this patient, what the heck must they do? And that's why patient gets placed onto empiric and often erroneous TB therapy. And also the system doesn't allow that doctor to always follow up that patient within a week or two to see if they respond. So that is a huge problem. I don't know. Oh, there you are. So there are no tools in the clinics, yet a patient cannot be referred to somebody like me without a diagnosis. And the point is that tissue has to be taken to rule out lymphoma. Lymphoma is not like, it's a cancer of the lymph and the blood system. So how can you rule it out by just pulling out some cells that are also part of the lymph and the blood system without really doing very specialized tests? So it doesn't work. So also getting a patient onto a surgical slate is incredibly difficult. So what about using a point of care method to actually get patients going? So what if we create a TB and lymphoma diagnostic inclusive pathway, and we do it in a non-surgical outpatient setting using a handheld point of care ultrasound? So that's what we did about 3 years ago. And if there was caseous material, then the patient only had that collected. If there was less, then we also did a tissue specimen with our biopsy guns. And the people who worked on this, we joined hands with the TB experts. Dr. Catherine Antel was the PhD student, and she was assisted by our other colleagues in the two young fellows in the clinic. So we called this the RADLAC algorithm because we enabled rapid access with a novel electronic referral method with a red cap, a link, so that patient and doctors didn't have to wait on us. And we did it in our clinic. So it was non-surgical people doing it. And, you know, when COVID came, it was actually very interesting to know that we are used to the shadow of an infectious epidemic, and how having this rapid way of referring patients really helped us, and also the point of care method. So I'll quickly try to show what we did. I think the let me show it. I think we must move. So the most poignant thing I actually heard was when we did our first workshop, where we taught generalists to do the biopsy as well as the expert ultra on lymph nodes. When a doctor of a clinic, primary clinic, said to us, "I do not know what's wrong with my patient. I cannot refer to any specialistic service, yet I do not have the diagnostic tools to attempt the diagnosis myself." So we tried to meet this need, and we did the 2 methods, accurate methods for TB and for lymphoma, and incidentally also for cancer of the lymph nodes. So we obviously used our point of care ultra, not point of care in our setting, but can be done at point of care. Let me rather put it like that. We sent it to the lab, and then we had our point of care biopsy method, which was sent to the lab for histological review. So what we then found is that, as everybody in this meeting probably knows, the WHO does recommend that this should be done on lymph nodes, but for some reason it's not done widely in South Africa. And hopefully, this will be done more widely. What we found in this paper is that, I'm not going to show that data, but we showed that it doesn't really look different in a HIV positive and a HIV negative patient. And TB and lymphoma doesn't really look negative. All these things cannot be diagnosed by looking at a patient. They really need these sophisticated tests. And we did found that the ultra had a good sensitivity and high specificity, and that it was also a higher yield than culture, and it was a rapid test. So we did use a composite reference standard, and let's see, it's about, of the 99 patients, we had 36 that had TB, and then we also had a sizable proportion with lymphoma. And the sensitivity was quite good. And when we used culture as the reference standard, the sensitivity was obviously a bit better. And we can see here what we compared it with: the low sensitivity for AFBs on smear and on tissue, and then the tissue culture that was only about 40% sensitive. So just the way we see the algorithm right now, if Purkacious material would be aspirated, then we would do an ultra and get hopefully to either a TB adenitis or a likely other bacterial adenitis. If there is no caseous material, then we would go over into the core biopsy, which can then easily handle the histology, the expert, and the TB culture. And you may ask me, where is the FNA? Well, the FNA is not useful in patients under 50 years old unless they actually either have a metastatic cancer, which is usually in those above 50, or these specific things that are cystic with specific symptoms of hoarseness, dysphagia, otalgia, and an FNA often with clear fluid, and these patients are best referred to an ENT specialist. So just to give a little overview of the patients we had seen until a few months ago when we did this analysis. And I'm not going to stand still at this. If people want to return to it, we can. But why does it matter? Why does lymphoma matter? And I just quickly want to run you through this. We always think it's prostate or breast or lung or colon or whatever, and all the other cancers, but actually hematological cancers are not that rare. And remember, non-Hodgkin lymphoma is vastly increased in our HIV environment. Now, competing reasons for dying could rule, could lessen that, but actually we're speaking of 100-fold increase of lymphoma in HIV patients. And if we look here, we can see that compared with the top cancers in the UK, that total blood cancers was very much near the top, near there, and just the lymphomas was almost at 18. So definitely, you know, really in the top, at least in the top 5. So why does it matter also? Because these diseases are the top responders to treatment, which people don't always appreciate. You can see that there are very few young men who have a testis CA, and they are very well cured. But Hodgkin lymphoma is the most serious cancer that actually, I'm not speaking of advanced melanoma, obviously, but early melanoma can be fairly well treated. But Hodgkin lymphoma is the serious systemic disorder that actually responds most well to treatment. The same for women, responding very well. So we should diagnose these patients. And I'm just going to show, going from the lymphadenopathy to the abdominal ultrasound, just quickly showing you a bit of work that we did. And also the background is that here from Harvard, there is this systematic review saying that actually, if there are splenic macroabscesses on the abdominal ultrasound in HIV patients, it's probably sufficient to initiate TB treatment. You know, but then you actually have to follow up the patient to see that they get better. And what if it is a different diagnosis, as I'm going to try and show you. And then nearer home from KZN, extrapulmonary TB diagnosed in a short period. There we see that the most common sites were pleural, lymph node, and abdominal. Microbiologically confirmation was obviously not as high as one would have wanted, and that the conclusions were that this is mostly extrapulmonary TB, and you know, calling obviously treating this better, but also lamenting that the screening tools are not necessarily optimal for extrapulmonary TB, which I can agree with, but then I would say let's do all of it better and get everything diagnosed better. So back to our colleague Gary, who published this paper with Roland Griessel, and they said that these 3 markers are independently predicting TB with a moderate diagnostic performance in seriously ill HIV positive inpatients. So a lymph node that's enlarged, splenic hypoechoic lesions, and then effusions. Now, could that also be seen in lymphoma? So we continued our work. I'm not going to spend that much time. I must say I can't see the time because of, but I think
you've got time, don't worry.
I'm still within time. Okay, I
Yes.
thought I'll catch up some time for Harry's sake. Harry, you're gonna say thanks for that. So I'll try to speed up. Anyway, so Eloise did the work where she actually looked at 34 of those patients that actually had ultrasounds of the abdomen. It's actually sad to see that of the hundreds that went through the clinic, only 34 patients had access in our setting to an ultrasound, because obviously they only came to us for the lymph node biopsy, and those who had lymphoma were then called back, and those who had TB were referred away for treatment. But we looked at this, and so these are the independent markers of extrapulmonary TB, namely the ones I've already mentioned: lymph nodes, ascites, effusion, splenic hypodense lesions, and here we have the 3 culprits. And we can, and what I want to draw your attention to, if you look at the tuberculosis and lymphoma groups, they're obviously small, but they are kind of even. And if we look at this, we can see that there's not that much to choose in whether these features were present or not between tuberculosis and lymphoma. Splenic hypodense lesions were more or less, it's all more or less the same thing. And where 3 features were present, we can see it's 2 of the 11 with TB and 3 of the 11 with lymphoma. And then when we did our sensitivity, specificity, and further tests, we can see that if we look at the features on their own, then we see some sensitivity and specificity, and hey presto, exactly the same with the TB. And if we continue to where three features are present, and we go in this direction, we see we almost have mirror images of each other. We literally, there's nothing to choose between patients with confirmed lymphoma in our clinic or confirmed TB in our clinic. So parallel to Eloise's work, we also did some work in the past 2 years with the bioengineering department, and Tareen Daywood did this very interesting work, and I'm going to spare all of you to know too much, to delve too deeply into all the machine learning contortions and algorithms that she carried out. I'm going to keep it very simple. She used the same features that Eloise used, plus Eloise actually had a list of 7 features, and Tareen used the same. And she looked at them all, and she did all her single vector model work on it. And so she could prove that she could develop a model. It seems I've got a slide missing, but that's not so important. She got to an 80% accuracy to actually predict by using these machine learning models, where she looked at the granularity and certain features in a machine learning model, in a supervised model that she developed together with Prof Mutswanga. And in that way, she could then show that she could actually differentiate specific features for Hodgkin lymphoma on the abdominal ultrasound. And also in her work, it was at least as accurate to diagnose for TB as for lymphoma in the abdomen. So, now we will go forward, and we will obviously continue doing work with our patients with lymphadenopathy, but also in the abdomen, to actually delve deeper, and hopefully delve deeper with our colleagues in the infectious diseases community and in clinics and in all strata of the healthcare services of South Africa, to look at how can we develop and make these tools really accurate and innovative, to use them in an algorithmic and in a sensible way to diagnose TB and lymphoma, to truly get to the bottom of what's wrong with these patients. So I want to thank you warmly, and I hope there will be some questions. So what my plea today is, obviously, let's connect with this other disease that seems to be so rare, but is not that rare in our patients. And think of the tools for lymphadenopathy, and think of the diagnosis, the differential for abdominal ultrasound findings. And let's work together. That's my call. Let's work together to impact guidelines and primary care protocols.
Thanks, Estelle. That was an eye-opening presentation. And I think that what really caught my attention was the primary care doctor saying, I know something's wrong, but I don't even know which specialist to refer to, because been there, done that, got the T-shirt. I guess one of the things that we do is that when patients present with lymphadenopathy, TB is the most likely diagnosis. And particularly if there's a pericardial effusion, the use of steroids is common. So then the patient will get better, not because we've got the diagnosis, but they'll get better because steroids are magical in that way. So it decreases the inflammation. Can you give us any other clinical pointers that we could use? And do we need to target the patients in whom steroids are used for closer follow-up?
Sure.
To exclude the diagnosis of lymphoma?
Francesca, that is now, you really get to the heart of matters. it's a tough one, very tough question, because, you know, who am I to tell, you know, people on the front line when to use steroids and when not? It obviously is a huge problem in lymphoma because, you know, we literally have had patients a year after being treated for this pericarditis on steroids, coming to us a year or so later with a very, very advanced lymphoma. Now, obviously, I'm speaking of a few people. That's not that type of presentation. Luckily, I can affirm doesn't get to us often. But how do you also lymphoma, not lymphoma iris? We're actually going to look at that. But TB iris, you know, those kind of things, steroids will be there. And all I can say from my side, I really can only say one thing. It is, if we can do more definite tests, let's please do them. That's the only thing I can say, because apart from that, I have no, you know, I really have no other help to offer. And that's why the tools are really the thing. Try to get stuff biopsy, try to do the FNA ultra at least, because I find that is now more widely used. But if it's not positive, and then, you know, in an appropriate tissue, you know, and it won't always be sputum, it please should be some other tissue if we think there's extrapulmonary. Obviously, part of our composite and our probable TB was, for example, if there's a TB, if there's an ultra positive test in a different site and the lymph node did not give us another diagnosis, then that patient was a probable TB. So it's always putting this stuff together. And just for Prof Eunice, I see he asked about the trace at the very beginning. In our setting, if it was trace positive and there were no other contradictory clinical findings, in those cases, we would have made it a positive for TB.
No, this is a complicated world we live in, with a high burden of HIV, high burden of TB. But as you pointed out, patients have a good prognosis if we find them on time. But if they are not found on time, then often the prognosis becomes poor. Let me just have a look if there are any other questions. How does point of care ultrasound help in sampling the patients? Eunice, another question from you. You are such a chatty one, Eunice.
It's very useful for, so we use that to at least make sure we don't put the biopsy gun into the a carotid artery. You know, that's kind of useful. And looking for cystic masses and so on, and really getting a feel for it. Now, theoretically, you could, I mean, radiologists do biopsies also in other sites, but they often use CT for that, because, you know, sampling even of lymph nodes in the abdomen, that would usually be done with CT. So I think it's indeed in the lymph nodes. There are certain signs, purported signs in lymph nodes that may be more for malignancy or not, but those we haven't been able to really, we haven't really done a study in it, but for the work that Catherine did, we could not see any difference really between the lymph nodes for TB or lymphoma. They are both, you know, rubbery, the same type of size. They're more often, a bit more often unilateral. And the ultrasound is truly just, I think, useful to make the clinician be comfortable with doing a gun biopsy and being in the right tissue. So I find that, just another answer, I find that the three clinicians who have been doing it in our clinic, they actually abandoned the ultrasound very quickly because they actually became quite proficient. So even a non-surgeon actually quickly becomes proficient, but it's helpful.
Yeah, that makes sense. And Eunice also asks about whether you transport the specimen to a pathologist on a slide or in a universal container. just to make sure that we're doing it correctly.
Yeah, Catherine had, I think it's probably not on my slide, but I mean, you all know how to send the sample on an FNA. So it's, you know, it's diluted with some saline in a little container, but I think that's not his question. Is he asking about the biopsy specimens? So they go in the normal way that biopsies would be going. So they don't go on a slide. And so this only slides we would be making would, if we would do a FNA, which we don't do that often in the younger patient, because we have really found that the FNAs are really, and the pathologists, and that pathologist echo that. They get thousands of FNAs every day, and yeah, the majority of them are just stuff. And it really doesn't say yes or no for any diagnosis.
Yeah, again, been there, done that, got the t-shirt, hoping for a definitive diagnosis, and you end up with, I'm not sure what this actually is.
Yes.
Estelle, thanks for a really interesting presentation, totally different from the others, but just reminding us is not everything is TB. And if we're going to treat our patients comprehensively, we need to bear that in mind.
Thank you, Francesca.
It's a pleasure. So finally, the last person we're going to go to is Monica, who's going to be presenting on the work of the TB think tank. However, I don't see her. She's been alerting us to the fact that she's been having connection problems. So I think what we're going to do at this stage is go to Limakatso and ask her if, yes, I don't see her. Ask her if you could please go ahead and do Monica's presentation. If she pops up and connection is restored, we'll go to her. But in the meantime, Dr. Lebina, can I hand over to you? Ah, the lights are back on, I see.
Yeah, it's a difficult evening in many places. Yes, apologies again for being disconnected just at the wrong time. And I hope I'll do justice to what Monica had prepared. And Harry, if you're also still on the line, if you just want to comment or add something, as you are also a member of the TB think tank, you are most welcome to do that. But I think as a start, just to say that we have been seeing a decline in estimated TB incidence since about 2009, more especially in the HIV-infected people. Probably the benefits of widely accessible antiretroviral therapy in South Africa. And the decline is less less in the HIV negative people over the years. And there's also been a sharp decline in mortality due to TB, especially among the HIV infected people as well. And the prevalence survey that was done in 2018 and the results were released earlier this year has also shown sort of a similar concern in terms of the number of TB cases diagnosed. According to the survey, they found 234 cases in the people they investigated, putting an estimated prevalence of about 852,000, and also indicating that there's about missing cases of about 154,000 per annum that are missed or not diagnosed based on the prevalence and the number of cases we diagnose as a country per annum. In the prevalence survey, one of the striking concerns was that most of the people that were diagnosed with TB were diagnosed on chest X-ray and they did not have any symptoms of TB. And about a third had both symptoms and an abnormal chest X-ray, and close to 7% only had TB symptoms and a normal chest X-ray. So they're still emphasizing the need to do more in terms of active case finding, as there are more people that we could be missing because they are asymptomatic or they do not have the classical TB symptoms that we are expecting and could possibly be diagnosed on chest X-ray and other investigative methods. This is the South African TB cascade that shows sort of the number of cases that get lost at each step of the TB treatment access. If we estimate that we have a prevalence of about 390,000 cases per annum, some will not get access to a TB test. Those that have accessed the test, not all of them will get diagnosed. Not all of them, probably because the test gets lost or the patient doesn't come back to get the result, or there was insufficient sample. Those that are diagnosed, not all of them are notified and treated, and only about 46% of the sort of estimated prevalence are actually cured at the end of the cascade. And at each step, we various cases. And the TB think tank was then established several years ago by the Department of Health with funding from the Gates Foundation and other organizations with sort of a vision to see how the researchers, the civil society and other organizations within South Africa can come together on TB programming and policy and new tools and sort of provide expertise, support, advice to the Department of Health in what other strategies to look into, how the guidelines could be implemented so that we can improve South African government programmatic TB response. The objectives has been to collate, review, synthesize, and evaluate evidence related to policy and implementation, and identify and prioritize research questions, and as well as advise the Department of Health on TB-related policy or guideline changes that could be required based on the latest evidence that has been shared or guidelines that have been released by organizations such as the WHO. And some of the outputs that have come out of this TB think tank has included policy briefs presented to the Department of Health on various topics, including how to increase access to health services for men, especially TB services, or to make them more friendly, including things like what kind of mHealth tools work in South Africa or could be recommended. I've also done reports to stakeholders, and as part of knowledge generation and sharing and skills sharing, we've had a few meetings and conferences and published some of the work done by the TB think tank. And that's sort of the composition of the TB think tank. It's chaired by the DDG, or the Chief Director for TB, and also co-chaired by one of the EXCO members. And currently the secretariat for the TB think tank is the Oram Institute. And we have various task teams looking at multiple things. Some of the task teams are optimizing treatment outcomes, service delivery, TB prevention, looking at new tools, as well as finding the missing TB patients task team. And each task team then has been focusing on various areas as the needs arises and new knowledge comes up. The finding missing TB patients has looked at how can mass chest X-ray be used for screening, looking at the South African context, what role can the ward-based outreach teams play in finding the missing TB patients, improving data recording and reporting for TB notification, so that we try as much as possible to close that gap between the prevalence cases and the cases that have been diagnosed. We've also worked with the other task teams about stigma reduction and initial loss to follow up. The service delivery task team has focused on mHealth and data issues and strengthening public and private sector partnerships. And the optimizing treatment outcomes is looking at multimorbidities associated with TB, patient-oriented interventions that can reduce the loss to follow-up and reduce mortality associated with TB. And we'll then have the TB prevention task team that has been looking at the guidelines, what vaccinations are available, what are the new research outcomes on vaccination for TB, TB epidemiology and modeling and new tools, which has often focused more on reporting and summarizing the new data that has been done by some group, and also supporting those that are doing that research on how they can get access to data to be able to fit into their models so that they more accurately reflect the context in South Africa. Yeah, and really the role of each task team is similar to the TB think tank, is to support in that particular section or a niche on TB program to the Department of Health and other stakeholders, and to also identify advocacy needs and drive the uptake of the priority interventions. And following the COVID-19 epidemic, there was a sort of a general consensus within the TB think tank that more needs to be done than what is currently being done in terms of increasing TB program activities, increasing access to treatment, diagnosing more TB cases, as all the indicators had sort of dropped during the COVID pandemic. And the things that were sort of considered as the focus area were how can we increase screening, and there was a self-screening app, which I'll talk more about, and also screening in shelters. And I think one of the big things that came into sort of recommendations from the TB think tank was a combined COVID and TB screening and investigation, as some of the symptoms between both TB and COVID are very similar. And to see how some of the new recommendations on systematic screening could also be implemented in South Africa, how we could possibly implement targeted universal testing, especially in the districts that are funded by various partners, whether it's a Global Fund or PEPFAR. There are also districts that are supported by Global Fund to start implementing digital chest X-ray screening based on the results of the TB prevalence survey that has shown that you can increase the number of cases diagnosed by just using chest X-ray, and as well as the private-public partnership improvement. There's been a lot of funding to go into that, to also as part of increasing the number of people investigated for TB, and making sure that the private general practitioners can also access the TB services for their patients. And looking at the whole cascade, of course, is also to make sure that we reduce the initial loss to follow up and support patients that were being diagnosed with TB to initiate treatment, and to see if the TB treatment, since it's also a chronic disease, can also be included in the CMDD, especially in remote places, and as people are becoming more and more uncomfortable to access health services during the COVID-19. And of course, all these recommendations also have to be communicated, and training and monitoring and evaluation were possible for all the interventions. And some of the communications included the launch of the TB prevalence survey, and the minister coming out to emphasize that we need to do more for finding the missing patients and other activities, and advocacy within TB and TB awareness activities has really increased post-COVID as part of the plans to try and catch up what was lost. and dissemination of monthly facility level testing volumes and results to NICD, especially with the co-testing for both TB and COVID-19. I think with the launch of the TB self-screening app, where you just say hi to that number and you then get followed by a few questions, and it is integrated with the COVID screening, and in a similar way, if you have symptoms, will then be told that it is recommended that you go to a healthcare facility and be investigated or screened further. These are some of the results that came from the app, and you can see number of screens with 40,000 and sort of the top rows. Positive cases screened to about 9,000, but only about 10 of them then access further investigations were considered needing to be investigated. 1,215 TB investigations were done, positive 133, and positivity of 10%. And on the left, it shows the usage of the app by province, and sort of looks like it was mostly used in KwaZulu-Natal, in Western Cape, and Gauteng, whereas provinces like Northern Cape, Northwest, Free State, there wasn't much utilization of the app based on this data. And some of the things that also came up was how to integrate the TB investigations at the primary healthcare level for those patients that are presenting with the possible TB symptoms, and the guidelines that were then recommended from the Department of Health was that those patients that present with COVID symptoms but their cough is of longer duration should be actually investigated for both COVID and TB. And there were guidelines included for screening for possible TB at the shelters, as there was an increase in the number of shelters that came up during the COVID lockdown. And this is also a population that is quite at risk of TB, as they also share common spaces. And this is the summary of the TAT results of the targeted universal testing study that I shared earlier, showing that if TB investigations are targeted to people at high risk, whether HIV infected or contacts of a TB patient, or they've had prior TB, then they will, there is a high proportion of them that will test positive for TB, even if they do not have the classical TB symptoms that we expect. In comparing clinics that implemented this intervention to those that did not, and with historical data, there was a relative increase in the number of TB cases compared to the standard of care clinics. And the other intervention that was recommended was increasing the LEM testing, especially in hospitals and primary health care. Despite the guidelines being out for many months and years, the uptake on the usage of LEM has been very slow, and it was recommended as yet another strategy to see if we can increase the number of TB cases diagnosed. And in an attempt to reduce the initial loss to follow-up SMS of expert results, whether negative or positive, to go by SMS to facility and also to be communicated to patients. And this is also part of the results of a LinkedIn study that has shown that this intervention, especially in Western Cape, where it's easy to automate most of these things because of the medical record systems that are being used, sending those messages can reduce initial loss to follow-up. And that's sort of more on the mobile notifications and how it could be done for either TB and COVID using the NICD tools. And then there was guidelines developed on the CCMDD rollout to support patients that have been taking treatment for TB for a while and are considered to be stable on treatment, but to also ensure that they can continue their treatment and collect it at another point or in a way that will make it easier for them to complete the treatment. I think, yeah, and for some of the things, let's see, this that have been sort of in a way beneficial for the efforts on TB screening and stigma reduction is some of things like wearing face masks for patients, and both healthcare workers have sort of become normalized, increasing compliance or adherence, and probably reducing the risk of transmission, although there is no data as yet. And healthcare worker TB contract tracing and TB testing for healthcare workers, and starting TB and PT treatment through the CCMD, some of the things that came out. Yeah, I think this was really done on behalf of the TB think tank, which is currently being supported by Oram Institute as the secretariat, and thanks to Salome and Monica and everybody for putting the presentation. And I'm sorry, Monica, that you couldn't share what you wanted to share with us. Thank you.
Thanks very much. Monica, I see you've been able to connect with us for a little bit. Do you have anything to add for the parts of the presentation that you did see? Again, I think it's great to see this. Monica.
Yeah, sorry, I keep on falling off, but yeah, I think I just wanted to ask about to actually just make a comment about the last but one slide, that the first cascade that was presented was on screening, diagnosis, and treatment. And the last one was focused on TB prevention. So those are the recommendations that we made to the Department of Health on TB prevention in response to the COVID pandemic. Sure, that's all I needed to add. Otherwise, thank you so much, Limakatso. I appreciate it.
Yeah, living in South Africa is just not for sissies. We've got to be adaptable and be able to change.
Yes, sure.
So if I have a look at all the questions, I think that the last question that we got is from Dr. Dlamini, and she's asking why the screening algorithm just shows a cough of over 2 weeks without differentiation by HIV status. We know that the standard 4-question screening, it's for HIV infected individuals, we say cough of any duration at all. And is there any suggestions as to why this hasn't been changed yet? Why HIV infected individuals are allowed to cough for 2 weeks before we screen them for TB, as it were?
I'll let Harry and Limakatso also just chip in, because they're part of the TB response team. But this is something that is discussed at every meeting. But I think the challenge that we're facing is because it's not in the current policies. So we actually have to make recommendations sometimes that align with the policies. And even though that is a recommendation in the WHO policies, but it will still take a long time to be approved by the Department of Health. So I still remember that there was that discussion about the policy and just perhaps coming up with interim guidelines. It's still under discussion, and it's still an issue that is being considered in this team. Harry, do you want to add?
Just to say that, yeah, I mean, we completely agree that it should be cough of any duration. It shouldn't be limited to cough of over 2 weeks. We've been quite frustrated with And, you know, I mentioned earlier that I was part of the Ntb summit with the 30 high burden countries globally. And it's quite remarkable. I mean, WHO recommendations come out and it takes 2-3 years before South Africa, as one of the high burden countries, adopts. And we really need strong advocacy to change that. So it needs to change. We have requested a meeting with the acting DG to consider the TB, or all of the recommendations from the TB think tank, including the systematic TB screening, incorporating TUT, and the TPT guidelines. And so we're trying to draw, you know, high-level attention to these efforts. What's remarkable to me as well is that in the context of COVID, where, you know, you can get all of the government ministers together and transform policy rapidly and start implementing things, that for TB, which has killed more people than HIV and malaria and plague and all of the other kind of infectious diseases over the last 100 years, we can't mobilize an intensive effort for rapid adaptation of innovation. So it's, you know, everybody on this call has a role to play in advocating for rapid adoption of innovations. Thanks.
Oops. Thanks, Harry. Just wanted to put my camera back on. So I think on that note, I'm going to draw this CME to an end. You're right. TB is not a sexy disease. It's a disease that affects people who perhaps are marginalized, often are poor, and live in difficult circumstances. Along comes COVID, and suddenly we have a vaccine. And everyone wants to talk about it. What we do need to do is leverage on our experience of COVID and make TB the new COVID, the thing that people are talking about, and reaching people with the message that we don't have a TB vaccine, but we certainly have TB treatment that can not only save your life, but it can also decrease transmission within the community. Thanks very much for everyone who's attended this very informative meeting. I think we had a really broad range, and I hope everyone has learned something new and will be putting that into their clinical practice. We are, of course, going to have another CME next week on Thursday, and we're going to be talking about the colliding pandemics. Seems like everything is a pandemic, but the two colliding pandemics of HIV and obesity. In the olden days, all of our HIV patients progressed and died. Now what we have in the year 2021 is really effective treatment for HIV. And what we need to be doing is paying attention to the other long-term problems of HIV-infected individuals. We've got to deal with smoking, hypertension, diabetes. And of course, what we've got to deal with is the colliding epidemics of both HIV and obesity. Thanks very much for attending, and I hope you've all learned something. Goodbye.
Thank you. Bye.
Thank you. Goodbye.